I'd like to ask a question, Dr. Chen. How long will it take to provide the report on the last, second last slide about the 400 gene tests?
Typically, it would take 2 weeks. Yeah, once the sample is qualified.
Dr. Poon has mentioned about the left and the right colon, which give very different prognosis. So a question to Dr. Chen, it will be, has anybody done any genomic study to look at the left and right, any difference in these two? Explain the difference in prognosis.
Actually, molecular characterization has already been done, so we know that right side of tumor tend to correlate with BRAF mutation, and also correlate with the worst prognosis molecular type, the molecular type 1. So the observation in terms of anatomical location actually correlate quite well with molecular classification.
In fact, the site, the primary tumor location is indeed the surrogate of underlying biology of the tumor. Yeah, for the left side tumor, usually more EGFR dependent, more common to have a EGFR wild type, and also if it is EGFR wild type, and also HER2 mutation is more common over the left side tumor. But on the other hand, right side tumor usually more like the more immunogenic type of the tumor, more common to have MSI high, more common to have BRAF mutation, or more common to have the RAS mutant. So indeed, the primary tumor location is the surrogate of underlying mutation, the genetic landscape of the tumor that determine the treatment, that predict the treatment efficacy and also determine the prognosis. It is not it's just a surrogate, yeah.
Any more questions? Yes.
I'd like to ask questions. I remember Dr. Chen at the end of the conclusion say that throwing a question that are we convinced that we should do all NGS for all colorectal cancers, now taking cause as apart. Would Dr. Au and Dr. Chen convinced that we should do NGS for all?
Yes, I do. I think that in terms of efficiency, if with the events in the more targeted therapies, I think that's the way to go. So for the time being, cost is the only barrier of adopting these strategies.
If the resources is not a concern, I think the answer is yes. I think NGS panel could definitely help us to identify some a rare mutation, some druggable mutation, and also important to predict pharmacogenomics of some conventional chemotherapy and even targeted therapy. But if resources is a consideration, if I could reserve the checking the NGS in the salvage setting, because normally we could only check the RAS, RAF, or even MSI in our routine clinical practice. But in the patient exhaust all kind of the option, even the TAS-102 and regorafenib, this kind of traditional salvage treatment. If some group of the patients still carry quite fit, quite keen for the treatment, and we learn from the data, we learn from the story of the BRAF and HER2. And if we can identify this selected subgroup, usually 3 to 5%, like BRAF mutation or HER2 mutation subgroup patient, we now have quite convincing data. There's some combination, like in HER2, we combine the lapatinib and herceptinib. Like in BRAF, we have regorafenib plus cetuximab. They can achieve the response rate quite high, up to 30 to 50%. It is unachievable by conventional salvage therapy. Usually the response rate is usually less than 5%. So if resources are constrained, I could reserve to use the NGS panel in the later line setting, in salvage setting. So it helps us to identify a selected group of the patient that benefit from some novel biomarker-driven treatment. Yeah.
Then I want to take the question a bit further, and also for Dr. Chen, is that As far as I understand, correct me if I'm wrong, is all these molecular studies are based on tumor samples from patients having advanced disease. Say for early disease, those just operated by Dr. Poon, who supposedly thought that these are all curable. Will there be some, can we get some insight from molecular studies on this one as to guide neoadjuvant treatment?
I'm not sure about neoadjuvant, but actually, if we're talking about selecting chemotherapy better suited for the patient, then I think this particular panel would definitely offer the information. And the other thing is that when we talked about MSI high patient, typically you look at the distribution of MSI high patient in different disease stage, then you will find that earlier stage 1 and 2, you will have about 15% of patients. But when it moved down to, for example, stage 3 and stage 4, it actually drops significantly. So that means that when we talked about patient goes through MSI high, MSI scan in order to try to get benefit from checkpoint inhibitor, then these are typically early stage cancer patient. So if we know that some patient will not respond and other patient may actually experience pretty severe side effect or maybe adverse effect, then these are the patient I would suggest to consider at least get, for example, a more comprehensive test. Since they are considering very expensive treatment, then this treatment should bring them benefit, or at the least we should try to avoid to do them any harm.
Currently, the NGS panel is checking the genetic signature. I think in terms of prognostic-wise, the WAS and also the WAF has prognostic implication for the patient during after curative surgery. Usually, the patient carry BRAF mutation. In general, there's still some conflicting there, but in general, it is believed it is associated with high chance of relapse, and also overall survival is inferior when compared to patient with BRAF wild type. And in terms of treatment-wise, indeed, some genetic marker may be useful to guide our treatment in high-risk stage 2 cancer, like the Oncotype DX, if there's a high score, may be more indicated for adjuvant chemotherapy in stage 2 cancer. And also MSI high is useful in high-risk stage 2 cancer. If the patient carry MSI high, there's some data suggesting that the patient may not be benefit from adjuvant 5FU or Xeloda treatment. So I think the usefulness of the genetic marker may be less in adjuvant setting when compared to metastatic setting, but I think there's still some huge potential awaiting us to explore. Yeah.
That means at this stage, you're still not convinced that we should do the NGS for all, including early stage colorectal cancer.
If resources is not a concern, I think it's always good to have more information and more insight on the biology of underlying tumor. Yeah.
Say practical question. Say, do you need fresh specimen? Is it better, or say if I do a cancer, I operate cancer, then is it better we order this immediately after the specimen is taken out and prepared, or say 3 years later, unfortunately the patient have lung met, but by that time we may not have tissue diagnosis because you don't want to puncture the lung, then you can only go back to this specimen 3 years ago. Mm-hmm. Then will it make a difference? Will all the DNA be destroyed or damaged?
Actually, we typically use FFP samples. So, because FFP samples over the diagnostic, also FFP sample allows us to perform macro dissection to enrich tumor. And so for most of our tests, the test was designed for FFP sample, actually for very lousy FFP samples. So if the FFP sample is preserved for like say 10 years, it's fine. Yeah.
May I ask a practical question? What's the usual turnaround time of this kind of tests? Because sometimes we order tests in salvage setting. The patient is already exhausted all kind of treatment. The prognosis is quite poor. So if the turnaround time is quite long, is maybe causing a problem that that the patient may deteriorate before the result coming back that guide our treatment. So I want to ask, what's the usual turnaround time of this kind of test? Yeah.
Typical turnaround time is 2 weeks, but I think we still experience some cases that patient is in such a terminal stage, then even 2 weeks is too long for the patient. But I guess at that kind of terminal stage, I also would not recommend, because patient, what happened is that when we identify a treatment option for the patient, and we actually observe that some patients experience symptom improvement, but their condition was just too poor to even go through to finish the treatment. So patient initially experience improvement, but I would suggest that when the patient is still in at least a good enough condition, not at the very terminal stage. Yeah.
Okay, then let me conclude the symposium tonight. And today we have eminent speakers on talking on this molecular aspect of colorectal cancers. And whether you are convinced or not to do NGS for all colorectal, I think you're convinced that they are all good speakers. And
Right, thank you. Before we head on to our dining table, the CEO of ACT Genomics would like to present some souvenirs for the chairperson and all the speakers for your effort. Dr. Chan. And Dr. Poon. Thank you, Dr. Poon. Dr. Au. Dr. Ching. And a very rare occasion, Dr. Chan to Dr. Chan. Yes, you are a speaker, so you get something from us. Thank you.